From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, JAMA Surgery listeners. This is Amalia Cochran, the web and social media editor. Today I am speaking with Dr. Anna Kowark and Dr. Mark Coburn. They are with the Department of Anesthesiology and Intensive Care Medicine at the University Hospital in Bonn, Germany. And our topic today is Preoperative Midazolam and Patient-Centered Outcomes of Older Patients. I was really excited to get the chance to talk to the two of you about this particular study because historically I feel like we have, as a profession, been very slow to embrace or highlight clinical studies that are essentially negative studies. And that's one of the reasons I actually think that your work is particularly impactful, since, to lead with the key finding, there were not any significant differences that were identified between the two groups. But before we get to the end of the story, I want to start at the beginning. And that is that I am always interested in hearing from our authors about their process with the development of clinical studies. Can you please share with our listeners what prompted the research question for this paper?
Yeah, I'm happy to do so, Amalia. One of the interesting topics in this project was guidelines suggest that we avoid benzodiazepines for pre-medication in the elderly patients, in a perioperative setting. However, if you look into the details of the guidelines, there's actually no evidence, no randomized controlled trials behind it. And therefore, we thought it's really important to assess this to see if a single dose, low dose pre-medication is kind of affecting the outcome of the elderly patient.
And it was also interesting because so many patients are still getting benzodiazepines. There was a publication which showed that 66% of the older patients, older than 65 years in the US, are getting midazolam pre-medication. And that was something what prompted us to do this research.
Exactly, that's the point. Guidelines kind of suggesting to avoid it, and still the clinical routine is kind of still using it.
Makes a lot of sense. With this having been a randomized controlled trial that involved multiple hospitals, how did you determine which hospitals to include in the study process?
Well, we wanted to include so many hospitals as we can, but as we didn't have any funding for this study, it was a voluntary participation in this study, and we have asked all the German hospitals which are interested, of course, in research. We have made advertising on the congresses for this trial, and also we have tried to contact colleagues.
Was the enrollment for the study balanced across the hospitals that did participate, or was there a little bit of an unbalance between them?
This is a project which kind of developed out of real pure research interest. And we had no funding for this project. So you need kind of funding. So we had internal fundings from our department. However, we couldn't give a case fee out to the colleagues who participated. And therefore, we were grateful to have colleagues who said, okay, this is a real interesting topic, we will participate. And thus, we were happy to have them enrolled in this project, but we were not able to balance between the centers. There has been a difference in the centers, yet we tried to take this into account when we analyzed our data.
And of course, the recruitment was not exactly the same in each hospital. Some hospitals have enrolled less patients than other hospitals.
That makes a lot of sense. It is very hard to balance enrollment when you are depending on the goodwill of colleagues to participate in a study like this. I completely understand. I noticed that you ultimately had to screen 5 times more patients than you enrolled in order to achieve the benchmark that you identified for the power calculation. And that includes that you had almost as many decline participation as you ultimately enrolled in the study. In hindsight, would you all have done anything differently with your inclusion criteria, or with the patient recruitment process that might have helped with this?
Amalia, I think this is a crucial point, and I think this is always the challenge we face. On the one hand, we want to have a perfectly designed study, to be as perfect, comparable in the groups, and that means a lot of inclusion, exclusion criteria. On the other hand, we want to have a pragmatic approach, so the results ideally should reflect our patient population we see each day. And we tried to be on the pragmatic side. For example, in Germany, benzodiazepines, midazolam is given orally. So that's the approach we took, well knowing that in other countries, especially in the US, pre-medication is in general given IV as example. And we tried to limit our inclusion and exclusion criteria to be able to involve or to enroll as many patients as possible. Yet we needed to incorporate the product-specific aspects of midazolam. Therefore, we had some exclusion criteria. And in general, I think it's quite challenging to perform studies in the elderly patient. And I think this is one of the big challenges we are facing. And also, there's a huge need to include, especially the elderly patients, in studies as they are increasing in numbers, they are increasing, or their outcome is of utmost interest, for our health systems worldwide. I don't know, you perhaps want to add some aspects on this too?
Yes, we had also the problem that 600 of the patients have declined the participation because one inclusion criterion was also if the patient wants to get benzodiazepines or does not want to get midazolam, then he cannot be included. So that's something what was also from our ethical committee approved. Oh, the study was only approved if we don't include patients who absolutely want to get midazolam. And okay, there are also, of course, some patients who never want to participate in studies. That's also among these 600 patients, there are also these cases. And I think if we do it again, the study, we would not make so many inclusion exclusion criteria and to have more patients included, like legally incompetent patients, for example, because for them it's also really important the result of if they get midazolam or not. So these patients were excluded here also.
That last group of patients is particularly complex because they are so important for a study like this. And the difficulties of obtaining informed consent because of human subjects protection makes the study so much more difficult to execute, much like including children in studies, because there are so many different levels of what you have to do to make sure that it's ethically conducted.
Totally agree, and that's exactly the challenge we face in the younger and the elderly patient. Yeah.
What do you all feel like was the biggest challenge in designing and completing your study?
One of the big challenges was the funding aspect. I think that's always a big challenge, and we are grateful we were able to perform this study. And secondly, you're learning in the process. And so we were in a phase also in the pandemic, and that really gave us a big backlash. So we lost a lot of time during this pandemic phase where we're not able to complete a study, do the analysis, and everyone was focused on clinical work, which is fine. But that was, I think, in this project, one of the biggest challenges we had.
Yes, the process at the end after the study completion was really impacted by the pandemic. And the other problems which we had were that we needed the placebo, of course. That means you need to involve a pharmacy. So that means you have to pay for them. And also, there were high costs which we had to pay. And also, the Open Clinica database had to be made. And so we needed money for this, also for these things, not only for the recruitment of the patients and completing of the case report forms.
Audits and all the things. Yeah.
Have your findings impacted your own clinical practice at this point?
So far, we had an open access, so the question of benzodiazepine premedication is really a hot topic in Germany. And based on the guidelines so far, most of the clinicians really suggested to avoid benzodiazepines in the elderly, let's say above 65 years, except for patients with high anxiety levels. Quite interesting, our findings have shown that there's really no, like you mentioned in the beginning, there's not a real big effect. Neither is it a positive nor negative. So it seems like the single dose effect of a low dose oral premedication with benzodiazepines, with midazolam, has a much lower effect as we actually thought it would have. That's, I think, a really very interesting finding. Yet in my department, the approach hasn't very much changed so far. Then at the moment we are still avoiding the benzodiazepines, and I think now with this data, having seen that, why would I give benzodiazepine premedication? Is kind of for the patient satisfaction, to lower anxiety levels. It seems like compared to the placebo, at least in this study, we haven't seen a big difference. And then I'm quite happy with the approach we're taking at the moment.
My last question for the two of you is if you have any plans for next steps that are outgrowths of this work. Are there questions that grew up while you were doing this work or analyzing your data that you are now interested in pursuing?
Yes, we need a bigger multi-center trial where we analyze also the patients who have not participated, who were excluded in this study, and where we also analyze, for example, the levels in the plasma of the patients. In our study now, we didn't do it. And also the blood pressure was also an interesting point, that the patients had a higher blood pressure who did not get midazolam when they arrived in the operating room. We think that it is very important to analyze this more in detail, if this has an impact on the patients, also for the patients who were excluded here in this study.
Yeah, and I think every study that's research what makes us tick, in my opinion. After a project, there are kind of new questions, and one point is I'd like to see also the effect of IV application of midazolam, for example, to make it more comparable to the States, for example, the approach. And hemodynamics is interesting. We see more and more patients coming with real high blood pressures into the OR. They're not taking their medication on the morning. And that could be an interesting aspect to see why actually clinicians are still giving the benzodiazepines. That's an interesting aspect. And then one limitation in our project was, yes, we had a placebo control, but no, we had nocebo control. So I think that could be an interesting aspect too, to have free arms. And we focused on patient satisfaction. And in our opinion, patient satisfaction is above all. But indeed, it would be interesting, to focus also on patient anxiety, for example. And in our study, we measured delirium, postoperative delirium. We all know it's a very important aspect. However, our patients, through our inclusion and exclusion criteria, had a very low incidence of postoperative delirium. Yes, so indeed, if we're running a new project, we probably would widen our inclusion criteria, would have more frail patients, would probably have a higher expected incidence of postoperative delirium. And so we could also see the effect of the benzodiazepine premedication also on other patient-relevant outcome parameters.
Dr. Kowark and Dr. Coburn, thank you both so much for spending some time with me today so we could learn more about your study.
Thank you.
Thank you very much.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you so much for listening.